Practice in family medicine and primary care, and we are striving also all the time to select the most prominent and eminent speakers that they can reflect the reality of our practice in family medicine on the topic they are going to highlight. So I would like to mention that this event is in partnership with the Saudi Society for Family Medicine and Community Medicine, and along with the International Medical Center. And today we are going to have a very special topic, which is related to bronchial asthma. And as you know, asthma is still a challenging clinical entity. It's yet underdiagnosed, misdiagnosed, undertreated, mistreated. There is a lot of pitfalls in our practice as a family physician, so primary care physician. Today in these presentations and in these scientific gatherings, we are going to shed light on the real-world practice of family medicine in the field of bronchial asthma. And we are privileged all the time to have one of our colleagues representing the subspecialty of pulmonology to add on top of what we are going to discuss today, the update and debate in the field of management of bronchial asthma. So today, I'm very pleased to have our guest speaker, Dr. Hiba Bizea, Dr. Mariam Sheikh, and Dr. Ahmed Jum'a, who are going to enrich our scientific gathering today with a lot of information and insight from their own clinical experience. I would like to introduce myself. I'm Dr. Ashraf Amir. I'm a consultant family medicine in the International Medical Center, and I have been privileged to moderate this session today. So ladies and gentlemen, just a small reminder and a housekeeping note. Please make sure that you put your Q&As in the Q&A box, and we will be able to pick up those questions which is related to the topic, and it will be forwarded to our guest speakers. The CME will be accredited as well, but there will be some kind of delay in the issue of CME because of the season of the vacations, but definitely we will be able to issue it as soon as we get it from the Saudi Commission for Health and Specialty. Special thanks for GSK for giving us this wonderful opportunity to be together today to share experience and to exchange knowledge in this kind of topics. So without any further delay, I would like to introduce our first speaker, Dr. Hiba Bizea. She's a well-known figure in family medicine, and she's one of our distinguished colleague in the family medicine department in International Medical Center. She has a vast experience in the field of many topics that is related to our topic today, which is bronchial asthma. And she's going to talk about the clinical approach. And this is a reflection of the real world practice of family medicine in relation to screening or diagnosing or even treatment of bronchial asthma. So, Dr. Hiba, thank you so much for accepting the invitation today.
Assalamu alaikum. Thank you for attending this event. I'm Dr. Hiba, consultant family medicine. Thank you, Dr. Ashraf, for the invitation and for the introduction. This is my first physical event after COVID, so it's a bit weird again. I'll be talking today about asthma diagnosis and management. I'll be talking in general about diagnosis and general management. I'll leave the review of updated guidelines to my colleague Mariam. So the objectives of this presentation, I'll start with the definition and the burden of the disease, the asthma control and exacerbation, and the discrepancy between the level of perception of asthma control among patients and physicians, and the risks of under-treatment. I will be talking about the reason for the paradigm shift of in asthma management, the recent Cena Guidelines. And as I said, the updated guidelines will leave it to Dr. Mariam. So I'll start my presentation with two questions. You will answer them now, and I will check the answers after that at the end of the presentation or not. So which of the following candidates for asthma? So one infrequent asthma symptom. Who says? So infrequent asthma symptoms less than twice a month. Anyone answers one? Okay, so we have one. Asthma symptoms more than twice a week. Two. So, two. Okay. Troublesome asthma symptoms most days. Three. Okay, one. Initially presents with an acute exacerbation. But so by the end of the presentation, inshallah, you'll know that. Second question: what is the preferred of asthma choice of asthma controller as per the latest Cena Guidelines? Daily low dose ICS lava. One. No? One. لا معنا one, but then we'll go to as needed low dose lava. Okay. You have to look at Dr. Mariam, she knows the answer. Low dose ICS lava, as needed low medium dose ICS, or as needed lava. So, but the presentation will go back to these questions. Okay, so what is asthma? Asthma is an indigenous disease characterized by chronic airway inflammation with symptoms, variable symptoms of upper respiratory symptoms, including wheezing, cough, shortness of breath, and chest tightness. And they vary in frequency and intensity with respiratory inflammation. It's common. Almost 239 million persons worldwide with an increased prevalence in the development. Essentially, serious chronic respiratory disease with complications, but it's not. So, we can see difference between normal airway concentration of inflammatory cells and global cell hyperplasia. Okay, so how to diagnose asthma in primary care clinic? What are the diagnostic criteria for asthma? So you have to have a patient presenting with respiratory symptoms, usually more than one, including either cough, wheezing, chest tightness, or shortness of breath. And these symptoms have to occur variably over time, and they vary in frequency and severity, and they have to be worse either at night or early morning, get worse when exposed to certain allergens, smoking, allergens, or during viral infection. And you have to confirm the diagnosis with a variable expiratory airflow limitation with a positive bronchodilator reversibility test. So this is a typical spirometric rating of an asthmatic patient. The red line before bronchodilator, you see a decreased FEV1 with at least 12% improvement after bronchodilator, and decreased FEV1 to FVC ratio, and usually we have a significant increase or improvement in lung function after 4 weeks of anti-inflammatory treatment. So how to confirm the diagnosis in a primary care clinic? Usually when most patients come to us, they are already taking controller treatment. So how to confirm diagnosis if this is really asthma or it's misdiagnosed? So if the patient presents with typical symptoms and airflow limitation, diagnosis is confirmed and you go to management plan. If the patient presents with variable respiratory symptoms but no airflow limitation, then you have to repeat the spirometry after stopping bronchodilators, and you have to stop bronchodilators according to the type of bronchodilators being used. So for SABA, you stop for 4 hours. For the twice daily ICS LABA, you stop for 24 hours. And for the once daily ICS LABA, you stop for 36 hours. Out during symptoms, and then you check the variability of baseline FEV1 and the bronchodilator variability. If FEV1 improved, then I cannot see well. Sorry, I'll just get my glasses. Can we go back, please? Can you see one? I'm not able to see actually, it's very blue. Okay, so I'll just say, so if the patient presents with very respiratory symptoms but no airflow limitation, then you have to stop the bronchodilators, as I said, depending on the type of the bronchodilator they're using. And then you repeat the, and then you repeat the spirometry. If negative, then you step down the controller treatment and reassess in 2 to 4 weeks. If positive, then you confirm asthma diagnosis and then you continue treatment as needed. If the patient presents with few respiratory symptoms and normal lung function with no variable airflow limitation, you repeat the bronchodilator reversibility test after stopping the bronchodilator. And if normal, you consider another diagnosis. You step down treatment. If symptoms recur and airflow limitation appears, then you confirm diagnosis of asthma and you go back to the management. If no change after stopping or stepping down the controller treatment, then you stop. The slides are Are you able to see? Okay, so how to step patients in primary care, how to step down from the treatment to help confirm the diagnosis? Our first thing, you have to make sure that the patient is fine, no symptoms, there's no acute changes like pregnancy, you don't try stepping down and during a viral infection, if the patient is traveling, if there's exposure to other pending exposure or risk of exposure to allergens, so you don't step down. So you assess the patient, you do the asthma control questionnaire, you do lung function, and if the patient, as I said, you choose a suitable time for stepping down the treatment, and you provide the patient with a written asthma action plan. We will talk about the asthma action plan later, and give instructions to the patient to resume their medication if asthma symptoms recur. And then you start reducing the dose of the ICS with the patient 5 to 50%, or stop any extra controller like LABA or leukotriene receptor antagonists, and schedule a visit soon, 2 to 4 weeks maximum. And then you review the response and you reassess the patient and assess lung function again in 2 to 4 weeks. If the symptoms recur and there is worsening in lung function, then asthma diagnosis is confirmed and you go to management of asthma. If after stepping down controller, no symptoms and lung function did not deteriorate, then you have to look for another diagnosis and you stop the controller medication. And you have to follow up the patient for 12 months. Okay, so what are the asthma triggers? There are different triggers like certain comorbidities and environmental factors like smoking, certain allergens, occupational, lifestyle stresses, exercise, medication like beta blockers or anti-inflammatories, viral infections, and comorbid conditions like allergic rhinitis, reflux, obesity, and sleep apnea. So when a patient presents to your clinic, you have to assess for 4 things. First of all, you have to assess for asthma control. You have to assess risk factors and try to modify them, to assess for comorbidities and treat them, and assess treatment issues, adherence, and compliance. So although there is evidence-based treatment for asthma in most countries, asthma control is still suboptimal and it is a major concern. Actually, 56% of patients are still not controlled. And this is associated with a poor quality of life, higher risk of hospitalization, emergency room visits, and consumption of healthcare resources. And variables associated with suboptimal conditions range from gender, age, smoking, and comorbid conditions. Local data in Saudi Arabia in the Asthma Risk and Insights Survey, it was found out that 7 out of 10 asthmatic in Saudi Arabia are not controlled or have poor asthma control. Another data from Saudi Arabia as well, where they had observed 1,000 patients from 5 tertiary care hospitals in Riyadh. Asthma control was complete in only 5%, and the rest either were uncontrolled or partially controlled. So reasons for poor asthma control starts with, and this is very important, wrong diagnosis, associated medical conditions not treated, exposures, adherence to medication and poor inhaler technique, and individual response to treatment. And one major reason for the poor control, which we play a role in, is the under-treatment. We don't step up treatment when we see risks of exacerbation. So again, 8 out of 10 patients thought that their asthma was controlled, whereas in reality only 45% whereas 45% of these were uncontrolled. In the INSPIRE study, majority of patients perceived their asthma control as relatively well, despite the asthma questionnaire finding showing that their asthma is partially or even uncontrolled. And the realized study as well showed a large gap between the perception of asthma control among patients and their actual GINA-defined asthma control. This is the assessment that I advise to use in your clinics if you don't do already. It's few questions and it tells you whether the patient is controlled or not. This is also a simple and handy measure. We can use it either in the clinic, in our clinics, instead of doing the spirometry like on every visit. The peak flow meter, we can use it at our clinic or if accessible for patients at home. We come now to the risk factor assessment. So we have to look for risk factors of exacerbation, which includes early sign of uncontrolled asthma, assess for comorbidities and treat them, advise patients to quit smoking, adequate use of inhalers, and the proper adherence and compliance with medication, and especially ICS. Risk factors for developing fixed airflow limitation, main reason is lack of ICS treatment and mucus hypersecretion or smoking. And risk factor for medication side effects, which is due to frequent oral corticosteroids and long-term of use of high dose or potent ICS and poor inhaler technique. Comorbidities. So, as I said earlier, you have to assess and treat rhinitis if the patient has reflux, sleep apnea, depression, and anxiety, pregnancy, and I missed to mention obesity as well, which is a risk factor as well, or comorbidity, frequently seen in asthmatic. Assess treatment issues. So you have to ask patients if they're taking the medication, if they have any concerns, if they're using the inhaler properly, if they have any side effects, the reason why they're not using their inhaler, and make sure that every patient has a written asthma action plan. Written asthma action plan has to have the actual medication of the patient. Proper instructions on when and how to increase the dose of the medication and when to start the oral corticosteroids, and how to assess medical care if symptoms fail to respond. This is a sample action plan. It's nice. It has all medication, patient's usual medication, instructions, when to access ER or healthcare. We'll come now to the management of asthma. About general management, brief asthma medication, treatment of modifiable risk factors and comorbidities, non-pharmacological therapies and strategies, and follow-up. So the long-term, what are usually management of asthma? The long-term goals of asthma management are to control symptoms and to reduce the risk of acute exacerbation, to prevent mortality, prevent visits or unscheduled visits to emergency room, to improve lung function, to avoid side effects, and to improve quality of life. And this has to be done in partnership between the physician and the patient. Non-pharmacologic strategies include, of course, smoking cessation, lifestyle, exercise, doing weight, smoking cessation, breathing exercises, avoiding medication that trigger asthma, and avoiding allergens. In the management of asthma, the main point that we need to stress in our clinic every visit is patient education and compliance of medication. About their inhaler skills. لأنه many patients, believe it or not, I had a patient yesterday, I wrote for her Rhinocort. In the pharmacy, they gave her Severity inhaler. And she came to me, how can I use this in my nose? So you have to ask the patient to bring their inhaler and show you if they're using it right or not. Adherence, written asthma action plan, self-monitoring of symptoms, and regular medical review. I don't think we do it routinely that we do follow-up spirometry for asthmatics once diagnosed. Do we? No, we don't. Okay. So why are we talking about asthma and the management and making sure it's controlled? Because even patients with mild asthma have a 12 to 36% of having severe exacerbation. A national review in the UK of asthma deaths, they looked at patients, 195 asthma deaths in the UK. They looked at them for 1 year prior to death, and it was found that these patients, most of them, they were not asked about the control. Most of them had higher prescriptions of SABA alone canisters and lower ICS containing canisters, which is, according to all studies, increased risk of mortality and morbidity, ER visits, ICU admissions. Not working.
السلام عليكم ورحمة الله وبركاته. Dr. Abdulaziz Twem, while we are making this here, I want just to mention one reason for poor asthma control in this country, and that is Abdulaziz Twem here. Just one thing about the reason for poor control, Dr. Hiba, is the wrong belief that if this child or girl get the inhaler, they will addict and they will become addicted. No. So they will keep, even if they use it when the asthma is over, they will stop doing that here. And the other thing which is also important is that to ask the patient during the exam about to breathe out and blow his or her hand. You can hear the wheeze. And the last thing, maybe I can say that not every wheeze is, don't forget foreign body children. And sometimes maybe it's not noticed. حبة حب ولا حبة كده دخلت في ده, causing wheezing for wrong. The question maybe I have for Dr. Hiba, what's your position on oral Ventolin syrup? They use it here widely and some practitioners.
It's not recommended, and in the recent guidelines, the evidence is against the use of oral Ventolin or thiophelin. I think it's the recent guidelines puts against. They should not use Ventolin alone at all, inhaled or oral. In patients with mild asthma who use as needed, they shouldn't use SABA alone. Whenever you use SABA, you have to have an inhaled corticosteroid with it. That's why we don't, usually I don't give my patients Ventolin, because when they, I will talk about it later on, but when they get the quick relief by using the SABA, they will rely on it. SABA alone doesn't treat the underlying inflammation, and it is associated with higher risk of mortality and morbidity, more exacerbation and severe exacerbation and admissions to ICU. That's why the recent guidelines, that's why there is a shift in the recent guidelines against, Dr. Mariam will talk about the tracks in the recent guidelines, Cena Guidelines, which talks about the option of SABA as a rescuer, but whenever you have one dose, you need to take in parallel an ICS. Okay? And if you are in doubt that the patient wouldn't do it, which happens most of the time, you shouldn't prescribe SABA. I can't hear you, sorry. Yeah, they have to use the Ventolin with an ICS. Because even those, as I said earlier, those with mild who have infrequent symptoms, they are at risk of exacerbation. Yes, thank you. The previous, please. Previous. Okay, so as I was saying, ICS treats the underlying inflammation, which is the core pathophysiology of asthma, whereas SABA treats only the symptoms. And we are still, as we're discussing, over-relying on SABA, and patients usually, whenever it was found out, actually, whenever they have signs of exacerbation, they increase their use of SABA instead of the ICS. Next, which puts them more at risk of exacerbation. Asthma treatment, ICS-containing treatment should be initiated as soon as the diagnosis of asthma is made, regardless of which step in the Cena Guidelines is the asthma. And if a patient has troublesome symptoms are waking up from asthma many times a week, then you have to start either a high dose, medium high dose ICS, or low dose ICS SABA in this case. Next, please. If the initial presentation is with severe uncontrolled symptoms or with an acute exacerbation, you give the patient a short course of oral corticosteroids and start regular controller treatment. This is in early presentation, first time. You step down the treatment if the asthma have been controlled for at least 3 months, except during pregnancy, infection, or travel, as we discussed earlier. And in adults and adolescents, ICS should not be stopped. So ICS has to be there all the time. Next. Before starting treatment, starting controller treatment, you have to make sure that the patient is really asthmatic, and this is difficult in 25 to 30% of cases. Many patients, they come to you already taking controller treatment, and we're not sure actually if they're asthmatic or not. And you have to document the risk factors. You have to assess lung function at diagnosis and then yearly after that, and train the patient to use inhaler correctly and do regular follow-up. And the asthma questionnaire, every visit, every 3 months, we have to assess for any signs of early exacerbation. Next, please. So if the patient is presenting for the first time, you should see them after 1 to 3 months of initiating treatment. And then if controlled, every 3 to 12 months, except in pregnancy, because pregnant ladies are at higher risk of exacerbation. And if after an exacerbation, you should see the patient within 1 week maximum. Next. اللي قبل, please. اللي بعد. Okay. So if the patient symptoms or exacerbation persist despite 2 to 3 months of controlled treatment, you step up. Dr. Mariam will be talking in details about the medications, which ones to use and how to step up and step down. And before you step up, you make sure the patient is compliant. There's no other risk factors or no other reasons for their respiratory symptoms like viral infection or comorbid conditions. Next. During viral infections or if there is an allergen exposure, then you step up treatment and you teach the patient how to change their doses according to the symptoms day to day. For mild asthma, in case the patient is taking a low-dose ICS formoterol for mild asthma or low-dose ICS formoterol as maintenance and reliever therapy. And to sum up, this is just the cycle. Every patient is unique. Management has to be personalized. You see the patient, you assess treatment, you assess side effect, you assess risk factors, you assess control, and then you adjust medication accordingly, and then you reassess and review. And thank you.
Okay, thank you so much, Dr. Hiba, for this illustrative presentation, which was quite informative. And my apology for the technical issues that we had. However, we will just continue our presentations with our second guest speaker, who is Dr. Mariam Al-Sheikh. Dr. Mariam Al-Sheikh, she's a consultant in internal medicine, and she's pulmonary critical care medicine from University of Beirut, and she's working with us in the International Medical Center. And most of the time, as a family physician, we depend on her because she is sitting on the other side of our healthcare system, watching us, all the time and looking into our performance. And we are exchanging, in fact, the expertise and trying to motivate ourselves to perform the state of art in management of patients with bronchial asthma. So thank you so much, Dr. Mariam. And I'm very sure that this presentation is going to be very unique because she's going to highlight the update guidelines, the medications and different steps that we would like to have in the management of our patients with asthma. So thank you so much, Dr. Mariam, for accepting the invitation, and the floor is yours.
Because the next will be very difficult with me, and I'm going by sentence. Can I have So this one is not working, no? Just minimize the slides. Yes, because then I'm putting some motion, so it's gonna be sentence by sentence, so it's gonna be difficult. Can I have the computer? Sorry, I think this is the best for everyone. Sorry. So now I can go. Okay. بهيدا. Okay, fine. Assalamu alaikum, good evening. Thank you so much for attending. And thank you, Dr. Ashraf, for this introduction. It's a pleasure to have life back again Alhamdulillah. أديها البطارية. Oh, but it's not working like that. Type. Put next, then we'll see what will happen. Okay, so this is the outline of our presentation. Let's go to the next slide, please. Okay, so yeah, so it's presenting as full slide. So I would like to start with a few case presentation. They were just challenging cases in the clinic. Just to tell you, not every asthma or presumed asthma is in reality a real asthma diagnosis. So it's a 17-year-old female patient. She's a healthy, fully active girl. She's been treated for asthma for the past 7 years. She's maintained on different kind of inhaler, montelukast, nebulizer. She's having frequent asthma exacerbation, and actually she's having copious amount of secretion. And then when it goes to a real physical therapy, as a physical exam, we found that she's having always unilateral wheezing. We went for a CT scan. Next. So we went for a CT scan for this girl, not mentioning receiving a lot of antibiotics every couple of months. So it revealed a right middle lobe collapse with bronchiectatic changes. And then we had to bronch this patient. There was no endobronchial lesion, and then respiratory culture grew Mycobacterium avium complex. Unfortunately, this patient lost to follow-up, but I believe she would have benefited from the treatment of mycobacteria other than tuberculosis, or even from a surgical resection of this isolated lung segment. Next. And next. Okay, another case. So these are real cases we've seen in the clinic. She's a 59-year-old female patient. She's been asthmatic for the past 20 years, recurrent and frequent asthma exacerbation, almost always every 2 to 3 months, with an emergency visit or hospital admission for asthma exacerbation. Every 1 year, almost ICU admission for asthma exacerbation. So she's receiving every kind of inhaler, nebulizer, systemic corticosteroids. And then she got admitted to the hospital December 2019 with an influenza pneumonia, as well as asthma exacerbation. She received many treatments for that, but she was slowly improving. So her chest X-ray was not really impressive. Next. That feel awkward. Okay, and then we had to do a CAT scan for her. Her CT chest revealed multiple bronchiectatic changes, mucus plugging, as well as cavitary lesion. Next, please. The next two. Okay. And then we had to do also bronchoscopy for her. There was copious amount of secretion, and then we did total immunoglobulin level, including IgE level that turned to be 4,000. So, and then we sent for specific IgE for Aspergillus, and it turned to be strongly positive. So this patient is a pure case of ABPA, and she's been missed for the past 20 years. This patient specifically, she's been following with us since 2019. Mashallah, she's doing great. She received the course of treatment for ABPA almost for 6 to 8 months, and she's doing great now on just very rare symptoms. Next, please. 2 more slides. Case presentation 3. More next. Okay. Again, next. Next. Okay. The last case, she's a 45-year-old female patient. Also, she's healthy, except for a wheezing upon exertion. And she was diagnosed as asthma. She received many courses of oral corticosteroids. She ended up, unfortunately, with osteoporosis as well as morbid obesity. She received different kind of inhaler, nebulizer, etc. And then she had a clear chest X-ray and a clear HRCT. And then we did the spirometry. Next, please. So that was her spirometry during 2019. Nothing really impressive in the numbers, but we're able all to see that there is kind of flattening of the inspiratory flow wave. Next, please. And then she lost to follow up. So that was her next spirometry after 1 year almost, and we're able to see more flattening of her inspiratory wave. So we're expecting kind of like obstruction in the airways. So we sent her first of all to the ENT team. So they just did a quick scope, and their finding is vocal cord paralysis. Actually, this is what we call exercise-induced vocal cord dysfunction, and nowadays they call it exercise-induced laryngeal spasm. And it's a typical wheezing with exertion only. This patient also underwent Botox injection for her vocal cords, and she improved dramatically, and she stopped all her asthma treatment. Next, please. Next. This just to remind you of the airway obstruction flow wave, how it showed. Next, please. Okay. So the first question, as you saw before, not every asthma is asthma in reality. So the question is, does our patient have asthma? And what are the diseases that mask asthma, and what are the comorbidities? Dr. Hiba talked about most of these details. Next, please. So again, history and physical exam. This is very important. Ask about the triggers. I would like to stress on one point, because I could have noticed the difference between working outside the kingdom and inside the kingdom. Actually, I think bukhur is one of the most important risk factor for asthma exacerbation here. I hope that the bukhur company won't kill me, inshallah. And we always underestimate metacolon challenge test or exercise challenge test. It's not available everywhere. But it's very good test whenever we have a challenging case, or whenever we have a non-confirmed case of asthma, mostly in adolescents. We have always to check for the condition that can mimic asthma, and what are the comorbidities. Next, please. Concerning the condition that might exacerbate, these are the symptoms that are typical for asthma, and the symptoms that should let us think about something else other than asthma. So what are the lowest probability for asthma? Actually, if you have an isolated cough, so I think this is mostly reflux or something else. It's not just asthma. We have a cough variant asthma which exists, and we can diagnose it by the end, but we have to think about something else first of all if we have just isolated cough. The copious amount of secretion, we should think about bronchiectasis. If we have a shortness of breath, mostly in adolescents and young adults associated with dizziness, lightheadedness, frequent presentation to the emergency, this might be just panic attack, not asthma. Chest pain, we need always to rule out cardiac event before saying this is asthma, even if our patient is asthmatic. Concerning the comorbidity, just speaking of this chest pain, I remember a study that was done locally in, I think, Indiana for asthma and COPD patient, and they just give them an action plan at home. So whenever you have increased shortness of breath and chest pain, start using the systemic corticosteroids, increase your dose, etc. And apparently at the end of the study, there was a highest mortality compared to the patient who came to the hospital because they missed the cardiac event. And these comorbidities are well known. I just want to mention obesity. There is a very linear correlation between uncontrolled asthma and obesity, and there is clear data about asthmatic people improving after a sleeve gastrectomy. Also drugs. We always forget to ask about drugs, especially aspirin and NSAIDs. Next, please. So what are the diseases that can mask asthma? As we saw in the previous few cases, always think about vocal cord dysfunction, or what we call now upper airway or laryngeal spasm induced by exercise most of the time, COPD. And not every COPD is a smoker patient. 20% of COPD are non-smoker. We have to remember the biomass COPD like bakhur and wood fire use. ABPA, as we said, the panic attack, congestive heart failure, they present with wheezing, a drug reaction, bronchiectasis, cystic fibrosis, hypersensitivity, some endobronchial lesion as mentioned before, especially in kids, foreign body, etc. Tracheomalacia, and we don't forget the Chord-Strauss syndrome. Next, please. So now we assess our patient for comorbidities, and we should reach a good diagnosis, how to assess asthma and how to classify asthma severity now. So next. Okay, so there are several numeric questionnaires. They're all almost the same. We have the asthma control test. This is the one used by the Saudi guidelines. And we have the asthma control questionnaire. And we have the GINA classification questionnaire. They're almost always the same finally, and they end up with the same correlation with symptoms and severity. Next. So after fulfilling the question, this is the ACT control. And the next is the GINA control. So basically, we don't need to memorize it. It's just 4 things. We have always to ask our patient. People doesn't like to fulfill questionnaire most of the time, unfortunately. So we can actually fulfill it in our head. How many times you had symptoms during the last 4 weeks, during the day, how many times you had symptoms at night, how many times you used your rescue inhaler over the past 4 weeks, and how many times you did not went to work or to school because of your asthma symptoms over the past 4 weeks. That's simple. And this is almost the same for the GINA questionnaire. Next. No major difference. Next, please. And here we can classify our patient as step 1 and 2, step 3, step 4, and step 5. So this is the first difference, is mixing step 1 and 2. So the GINA guidelines, previously 2021, they used to classify patient as mild and mild intermittent. So the mild, the people who are having symptoms less than twice a week or less than twice a month, even I forget. And then step 2, the one having symptoms less than twice a week. And as Dr. Hiba explained in the previous, that the study showed that these 2 categories have the same asthma exacerbation prediction and severity. So they combine both with the symptoms less than 4 to 5 times a day days per week, and there is no night symptoms. Step 3, symptoms most days of the week, and there is night symptoms at least once. Step 4, daily symptoms, and more than 1 night per week symptoms, and low lung volume on spirometry. And step 5, the patient who are not improving on previously mentioned treatment. And after stratifying the patient like that, we should start the treatment according to the GINA or the Cena guidelines. So let's assume that we start the treatment, and then we'll talk about it in detail in a moment. We should reassess our patient after treatment. Next, please. So how do we assess our patient? Dr. Rahib also mentioned it all. It should be a close follow-up. Spirometry. Unfortunately, we have a lot of logistics here, like insurance not approving spirometry every now and then. People does not like to do spirometry every now and then. Peak flow meter is not available everywhere. And so we go by clinical. We go by the questionnaire. We go by assessing how they are using the device, the compliance. And here we go. So next. So now we can classify our patient after treatment as mild, moderate, and severe. Mild, the patient who are improving on step 1 and 2 asthma treatment. As we said, there is no more intermittent or mild persistent asthma. Moderate asthma that are well controlled on step 3 and 4. And severe asthma, and this is a very important point, the people who are not controlled on high dose ICS LABA. So what's the definition of severe asthma? Next. Actually, this is the IRS ATS definition, and it's been there for so many years and it's still the same. Severe asthma are the asthmatic people who are requiring very high dose of ICS, very frequent exacerbation, recurrent use of corticosteroids, systemic corticosteroids. So if I have more than 2 exacerbations per year, requiring more than 3 days each of systemic corticosteroids, so this is non-controlled severe asthma. If I have at least one of them requiring hospital admission, so this is a severe asthma per year. If I have a patient who always exacerbate in clinic after tapering down the corticosteroid, so it's a severe asthma. Next. And now I need to go on a hands-on treatment in the clinic. So we always read high dose ICS, low dose, moderate dose ICS. But unfortunately, at the end, I think we all prescribe the same inhaler. So what does it mean, low and medium and high dose ICS? Next. So I think the most commonly used in the kingdom is budesonide, fluticasone furoate, and fluticasone propionate. So budesonide is the one in Symbicort, I guess. I want to mention name just for practice issue. Fluticasone furoate, the one in Relvar, I guess, and for sure, of course, and the fluticasone propionate, the one in Seretide and in Frutiform. These are, by practice, the most commonly used inhaler, at least in Jeddah here. So, budesonide, 200 to 400 is the low dose, 400 to 800 is the medium dose, and high dose is more than 800. Fluticasone propionate, 100 to 50 is the low dose, 250 to 500 is the medium dose, and more than 500 is the high dose. So we'll calculate numbers in a moment. Next, please. These are the form of Symbicort, for example, the 160. The numbers always go for corticosteroids. And we have the Symbicort, for example, 80. We have the what we call Pulmicort or budesonide 200. Next, please. The Seretide, the different form, we have dosage of corticosteroids going from 50 to 500 in different forms. Next. The Frutiform, the 125 and the 200. And next, we have the Relvar, I think, the 100 and the 200 doses. What does it mean? It means if I prescribe Symbicort 160, which we almost all do it, I think, to puff twice a day, the patient is receiving 640 microgram of budesonide, which is already a medium to high dose of corticosteroids. So already and automatically by default, I labeled my patient as kind of like severe asthma, actually. And he might not be a severe case at all. If I prescribe Seretide or Frutiform, for example, the 250, which is to puff twice a day, which we always do, of course, most of the time, and then we just automatically refill the medication, this patient is receiving 1,000 microgram of fluticasone per day, which is beyond the high dose, beyond 800 microgram. The Relvar 200, the 200 microgram of fluticasone furoate, this is already the high dose because the low and the medium dose is just 100. So we should always review our medication and step down or up the patient, not just automatically refill the medication. Now, what is the Cena and the Cena guidelines? Next, please. So Cena, after confirming the diagnosis, after addressing all the comorbidities and the confounding factor, inhaler technique and adherence, because you would see ajaib in the clinic, how they use the inhaler. And now they just put two pathways for treatment. Pathway 1 and pathway 2. Actually, I want to mention a big title now here. I think we all learned, even in the med school, because it's well known and established for so many years, that no one is using a LABA alone, a long-acting beta agonist, and it's prohibited to have a device of long-acting beta agonist alone, because it's well known historically, many evidence based on that using LABA alone increase mortality in asthma. And this is the new evidence concerning the SABA, the short-acting beta agonist. Nowadays, we know well that using SABA alone without an anti-inflammatory and inhaled corticosteroid will increase morbidity and put the patient at risk of severe asthma exacerbation because of the airway remodeling. So there is no more SABA alone. And I think maybe practice-wise, they should do like they did with the LABA. There shouldn't be any device of SABA alone, actually. It should be all combined. Hopefully it will come soon, inshallah. So this is an idea for the company if you want to go for that, the GSK company. Okay. Sorry, can you go back, please? So pathway 1, they use the low dose ICS formoterol as a quick reliever. And the pathway 2, they left the SABA, but they will remind us of using the ICS always with it as a reliever. So as we classified our patients, step 1 and 2, 3 and 4 and 5, we'll start with the step 1 and 2, the people who are having symptoms less than 4 to 5 days a week. So this patient will do very well on A low dose ICS formoterol as a reliever therapy. What does it mean, low dose ICS formoterol? Also not speaking name, just as practice example, the most commonly used are Symbicort and the Flutiform containing the formoterol. It means if I will use the Symbicort 160, it's gonna be just one puff twice a day as needed, no more than that. And fluticasone propionate, for example, the Flutiform 250, it will be just one puff once a day as needed, also no more than that. Next. If the patient is a step 3, so he's having symptoms most of the day and once at least per week at night, waking up. At this time, we should put our patient on a maintenance dose ICS formoterol in the pathway 1 on a daily basis. It means Symbicort, for example, 160, one puff twice a day, not two puff twice a day, on a daily basis. And Flutiform 250, one puff per day on a daily basis. Step 4, next please. If the patient is having daily symptoms, frequent night symptoms and low lung volume function, they should be on a medium dose. So now we can increase our corticosteroid dose to 400 to 800 or 250 to 500 in the fluticasone propionate. And in certain situation with acute exacerbation, we should add oral corticosteroids for a few days. Next. In step 5, of course, we should go for the high dose ICS formoterol using budesonide more than 800 per day or using fluticasone propionate more than 500 per day. We can add a long-acting anticholinergic. We should go, of course, for phenotypic assessment for possible biologic treatment, including anti-IgE, anti-interleukin 5 and 4, and of course, a short course of oral corticosteroid will be helpful to finish the acute exacerbation or the severely uncontrolled symptoms. Next. So that was the pathway 1. So pathway 1 does not contain salbutamol, does not contain SABA at all. Pathway 2, step 1, if the patient is having symptoms less than twice a month, so they can use SABA as needed, but they should use inhaled corticosteroid with the SABA. So at this level, I should give the patient 2 devices. I should tell him, whenever you feel short of breath, once or twice per month, you should use the Ventolin and you should use your inhaled steroids at the same time with the Ventolin. That's simple. Step 2, if the patient is having more frequent symptoms, he should be maintained on inhaled dose ICS, which is low maintenance dose. Step 3, now we should go for a low dose maintenance ICS LABA, regardless of the LABA, so any inhaler can work here. Step 4, we should go for a medium to high dose of maintenance ICS LABA, and step 5, as we mentioned previously, the same situation. Next. What about step down treatment? Dr. Hiba, I think, talked about most of it. So frequent follow-up, slow taper down, and choose the good timing for taper down and step down treatment. Next. I would stress on a very important point here is whenever you want to discontinue the long-acting beta agonist from the treatment, for example, my patient is on a maintenance ICS LABA and has been low-dose maintenance ICS LABA and has been well controlled for more than 6 months, for example. Now I want to stop his LABA and put him on a maintenance low-dose ICS only. This should be very careful with a very close follow-up in the clinic. That's it for the step down. Next, please. Okay, so again, the updates. No more SABA use alone for asthma in adults or adolescents. No more Ventolin alone. A patient with asthma receiving SABA alone, we know that they are at increased risk for morbidity, exacerbation, hospital admission, mortality, lung remodeling, etc. Okay, we talked about everything. For the short acting using ipratropium, it might be an alternative for SABA, but there is no clear evidence so far about it. No more oral salbutamol or theophylline, just very high toxicity window, so no more recommended in the Cena Guidelines. And the rapid onset LABA formoterol is as effective as SABA as a reliever. We need to tell our patient to reassure them that this device will be as effective as Ventolin, so we don't have to worry about asthma or symptoms relief. Next, and this is evidence A, of course. How about the Cena Guidelines? So actually, it's almost the same previous guidelines, and then they just added a few steps. So as a reminder, they use the ACT test score, questionnaire score, to stratify the patient. Next. Approach for treatment initiation, they have step 1, 2, and 3 only. If the ACT is above 20, so the patient is well controlled, so they just either recommend formoterol ICS as needed or low dose ICS as needed in a special situation, and they did not mention the SABA, but I believe they mean the SABA by default with it. Step 2, if the ACT is between 16 and 19, which is partially controlled status, they would put the patient on a maintenance ICS, SABA as a reliever, or a combination, low dose ICS and formoterol as needed, or they can add on leukotriene antagonist. Step 3, low to medium dose of combination, of course, and a patient presenting with severe symptoms, consider oral corticosteroids, of course. Step 4, I think, next. Yes, this is for the initiation of treatment now, how to assess control of asthma while patients are maintained on treatment. If the patient is well controlled on step 1 treatment, so he's having a mild asthma, so we'll keep him on the same low dose combination as needed or ICS and SABA as needed. This is almost the same as Cena Guidelines. There is no major difference. Step 2, maintenance low dose ICS, and you can have always SABA as needed with a maintenance low dose ICS or a formoterol ICS as needed. In the moderate, a maintenance combination, they can increase the dose of ICS. Sometimes you can add leukotriene antagonist, or they can increase the, they can add theophylline. They did not remove the theophylline yet from the Cena Guidelines. And step 4, now, next please. Okay, step 4, here they increase, so the patient, despite being on treatment, is not yet controlled, so they increase the ICS to medium to high dose. And they can add LAMA and leukotriene antagonist. Step 5, now we should go for phenotyping and consider biologic treatment. And less preferred controller, low dose oral corticosteroid. And I think we've seen a lot of patients maintained on a very low dose of prednisolone, like 5 or 10 milligrams to control their asthma. And these people, the priority is to taper down this oral corticosteroid as much as possible and then consider biologic instead. Next. I think I'm done. Thank you. I forget to put the thank you anyway. Thank you. I think there was a 54 next in the, sorry. Thank you.
Thank you so much, Dr. Mariam, for this illustrative presentations. And now, because of the short of the time, we are going to move to the third speaker, Dr. Ahmed Artefa. He's the medical advisor of GSK supporting respiratory portfolio, and he's a respiratory medical affairs expert and a lecturer in a scientific education GSK event. He's going to shed a light now on the role of proactive regular dosing in achieving asthma control. So the floor is yours.
Assalamu alaikum. Good evening, everyone. Actually, it's my pleasure to be with you today. And on behalf of GSK, I want to express my sincere appreciation for the organizers for being part in the educational event. So today I will share with you the importance of PRD, proactive regular dosing, and how can we help patients to achieve control using proactive regular dosing. And also the second part of my lecture will be about the proper use of SABA, because we have a recommendation from most of guidelines to stop using SABA at all alone. So first part of my presentation about the science of PRD. Role of PRD in achieving control, proactive regular dosing. Next, please. Next. As you see here, the burden of the individuals and for asthma, more than 262 million of patients suffering from asthma, and also for asthma-related deaths, approaching 461,000, and even the economic burden for the resources for achieving control or for managing asthmatic patients, more than 300 billion for direct medical costs. Next. So I will talk about the main challenges in achieving control and the main challenges in controlling and achieving the high level of control. As mentioned in the previous lectures, that the level of control is still challenging, and we have low level of achieving control. So regarding the challenge in asthma management, next. This is the decline in the death rate for asthmatic patients. As you see here, we have a significant decline in death rate for asthmatic patients. However, we have in the recent past years, we have a plateau in the decline of the deaths. So we need other approaches. We need to be focused in a very important way to continue decline in the death rate. Next. And for the second challenge, which is the patient perception. Patient perception is very, very important in asthma management. As you see here, some patients, around 83% of patients consider their asthma is controlled. However, majority of those patients are not controlled. And around 57% of patients who were uncontrolled, according to Cena Guidelines, those patients don't consider their asthma is serious. And around 44% of patients ignore the asthma and ignore the treatment at all. So the patient perception is totally different, or there is a controversial perception between the actual status of control and from the perceiving of the patient about their control level. Next. So for poor perception of asthma symptom may lead to over or under treatment. So if we rely on the perception of patients, so maybe the patient received the treatment in overdose, or maybe under use of their treatment. That's why we are focusing on PRD, or proactive regular dosing, to provide the patient with the optimal dose of ICS or ICS-LABA to achieve control, rather than to rely on the perception of patient, because majority of patients still don't have the accurate perception for their asthma. Next. So the science of PRD. Next, please. Goal of asthma treatment, as you know, according to Cena Guidelines, to target both to achieve good control of asthma symptoms, and to minimize the risk of the future of exacerbation or airflow limitation or inflammation or even airway remodeling. So to focus both phases for asthma management, we should focus on the two aspects: achieving symptom control plus minimizing the future risk of exacerbation or airway remodeling. Next. So in achieving control or managing asthmatic patient, we have two aspects. First one, which is the visible part of the outcome, which is exacerbation. We can assess the frequency of exacerbation, we can assess severity of symptoms, and even sometimes we can assess the lung function. Those are the visible part of the asthma management. However, we have invisible part or invisible outcome in achieving or in managing asthma patients, like hyperresponsive airway inflammation and airway remodeling. So if we want to achieve the proper level of control, we should focusing on visible part and invisible part. By regular dosing or proactive regular dosing, we can achieving this type of management to tackle or to target visible and invisible part as well. Next. So if the patient receiving the treatment in a reactive way, or when worsening the symptoms, receiving the treatment, and after improving the symptoms, stop the treatment, this patient will improve symptoms and exacerbation alone. And if patient receiving the optimal dose of the ICS on a regular basis, we can tackle and improve all these aspects. So proactive regular dosing is a comprehensive approach to achieve and improve all these aspects: airway remodeling, minimization, airway inflammation, hyper-responsive airway narrowing, and also to improve symptoms and reduce exacerbation. Next. So early initiation of ICS, we are all aligned on the importance of initiation of ICS as early as we can. This is different types of patient. Patient initiates after onset of the asthma after only 2 years. And some patient after 2 to 3 years of the onset of asthma, after 5 years. So as long as we initiate ICS early, we can maintain the lung function as much as we can. Next. So how does PRD help? What is the outcome? What is the main benefits of PRD, or proactive regular dosing? This first one, regular dosing treatment improve asthma control. As you see here for the patients, if we compare between patient receiving daily ICS or regular inhaled corticosteroid versus patient using intermittent dosing, the improvement in asthma control will be significantly improved with patient receiving daily ICS. Also, for symptom-free days, there is a significant improvement in the symptom-free days when patient receiving daily dose on regular basis versus patient using intermittent dosing. Next. Also, there is an important part of the underlying inflammation, because we cannot assess most of the time the level of inflammation. So if patients, or if we compare between patients receiving regular dosing of inhaled corticosteroid, the inflammatory mediators will be decreased significantly versus patient using intermittent or using reactive or symptom driven. When he feels some worsening of the symptoms, receive treatment, and after improvement, stop the treatment. So intermittent or irregular using of the treatment will not reduce the inflammation. However, patient receiving regular dosing can reduce the inflammation significantly. Next. Also, early and regular treatment with ICS improve lung function and also to prevent exacerbation. This is also to compare between the patient receiving the regular dosing to improve exacerbation or reduce exacerbation and improve the lung function. Next. This is from the GOAL study. GOAL study, as you see here, starting from day 1 across 1 year. As long as patients receiving regular dosing, number of patients achieving control increased gradually, and all patients, or maybe majority of patients achieving control, sustain the control across 1 year. So not only patient will achieve control, but also the patient will sustain the control across 1 year. And this is from the GOAL study in 2004. Next. So regular ICS LABA reduce exacerbation versus ICS alone. This is also from OSTRI study and the GOAL study. So we are comparing between patient receiving irregular versus patient receiving regular dosing of ICS. So this is a comparison between patient using ICS LABA versus patient using ICS alone. So improving in the exacerbation is significantly improved with patient using ICS versus patient using ICS LABA. ICS LABA is improving more versus patient using only ICS. So this is the importance and the significant reduction in exacerbation for patient using ICS LABA from GOAL study and OSTRI study. Next. So the second part here with the effect of regular ICS on SABA use. All we know that we received significant or maybe the newest recommendation from the guidelines about avoid over-reliance of SABA, and this is very important from the majority or maybe all guidelines to recommend avoid over-reliance on SABA and also to avoid the using SABA alone. So what I want to share the proper use of SABA. How can we use SABA in a proper way, and what is the importance of using SABA as recommended from Cena Guidelines, and how can we recommend the proper use of SABA with our patients. Next. If we compare between 3 types of patients, first one don't receive at all ICS. Second one is increasing ICS, but not optimal. And the third one, receiving the optimal dose of ICS. The frequency of SABA will be decreased significantly, which means that when patient receiving the optimal dose of SABA to control symptoms, to control exacerbation, to achieve control, as long as I'm receiving the optimal dose, SABA will be decreased significantly, and use of SABA will be decreased significantly. So patients, when receiving optimal dose, will not be exposed to over lines of SABA. Next. This is to confirm that patients receiving regular dose and optimal dose of ICS and will not be exposed to excessive use or inappropriate use of SABA. Very minimal number of patients or percent of patients will be over reliance on SABA when they receive ICS. That's why we are focusing and confirming on the using of PRD or proactive regular dosing to initiate the optimal dose of inhaled corticosteroid to avoid over reliance of SABA and also to achieve control with those patients. Next. So one of the importance and maybe the benefits of using SABA, it will be a very simple and convenient indicator for the control. So if patients receiving optimal dose of ICS or ICS LABA, it will be a very important indicator for patients. If patient receiving the optimal dose of ICS, it will not receive or use SABA more than twice per week. If patient receiving more than twice per week, this means that patient is out of control and we need to increase the dose of ICS. So using SABA optimal or proper use of SABA is very important. Using SABA as an indicator, convenient and simple indicator for the control is very important for the patients. So as you see here from the GINA classification or the GINA evaluation for the control, we can know the number of frequency of using SABA to know the level of control for the patients. Next. So this is from the modeling study, which is a recent study to show the importance of using proactive regular dosing or regular dosing for patients, comparing between using PRD and MART studies. I think if we see the thresholds of achieving control, almost majority of patients using PRD or proactive regular dosing can achieve control. And this is mentioned, as you know, in the Cena Guidelines. The majority of patients can achieve control with ICS salmeterol. So this is confirming also the safety of achieving control during the journey of achieving control. The level of safety or maybe cortisol suppression is almost within the normal. So we can achieve control without compromising on the safety. Next. So why do we prefer proactive regular dosing? First one, for even though patient may perceive their asthma as control, however, those patient is uncontrolled, so we cannot rely on the perception of patients. Second one, GINA definition of asthma control involve assessment of post-symptom control and the future risk. So in proactive regular dosing, we can reduce exacerbation, we can improve symptoms, and even we can minimize the future risk of the complication of asthma. Also, for the regular or flexible dosing differ in airway efficacy and systemic activity, as mentioned in the modeling study. This is a recent study published in March this year to show that the patient using regular can achieve control without compromising on the safety. And fluticasone propionate salmeterol is proven to achieve and maintain asthma control. This is and reduce also exacerbation, as mentioned in the GOAL study and also in the Cena Guidelines. So this is the summary. Regular dosing outperform symptom-driven dosing in symptom control. We can achieve symptom control. Also, we can improve and maintain lung function by proactive regular dosing. Inflammatory markers reduced significantly with patient using proactive regular dosing versus patient using intermittent. And also regular ICS is non-inferior to symptom-driven dosing in reducing rate of exacerbation, which is one of the proven outcome to reduce exacerbation. Next. So at last, this is a seretide, just to remind you by seretide. This is the discus for one buff twice daily. This is for the patient, and this is easy to use device to minimize the handling errors may be happened during the handling of the seretide. So in conclusion, I just want to share the importance of PRD and how can we maximize the outcome of using PRD in terms of reducing symptoms, relieving symptoms and reducing exacerbation, and also for the other outcome in reducing underlying inflammation and minimize the risk of airway remodeling, and also to focus on the proper use of SABA and avoid over-reliance, and being the indicator simple and convenient for the patient to achieve control by proactive regular use. That's from my side. Thank you.
Okay, thank you so much, Dr. Ahmed, for this brief presentation. And I would like to invite all our guest speakers to have their position on the stage so they can answer the questions. We have a couple of questions that we received from our audience virtually, as well as I will open the floor for our... Would you like to come here? Yes. Dr. Ahmed. So we'll open the floor now for any questions from the audience here. Anyone has a question, so please raise your hand. Dr. Muhammad Abu Nawas. Mike, please. Mike.
Thank you very much. I think we received tonight just overdose of asthma. We passed through all those cold cases. There is critical cases which we need, to attack, especially if they develop with indigenous eczema and they got that kind of stridor, and they might be, it's a life-threatening cases. So I think maybe it's a recommendation for a lecture and a workshop in the future. But my other, I split my comments regarding the obesity, especially we have 40% of the pediatric obesity in this country, plus the adult. And the combination of obesity on respiration and the following with our polluted atmosphere. So how you manage those cases regarding, not only on medication. I think we need, to just two suggestions. One, I think we need, to use the WhatsApp so we can send to them, everybody got a mobile. Second, I think for their home, I think a home care should get an inspection. Thank you.
Okay. Dr. Muhammad, any comments on what he said, Dr. Muhammad? Obesity and bronchial asthma?
Yeah, I think it's a very important healthcare issues, obesity and asthma, or obesity and respiratory disease, going from deconditioning and loss of performance until a real pathological disease. So it should be tackled in home healthcare. It should be tackled in social media. It should be tackled everywhere. There is a strong association between obesity and all kinds of respiratory disease. Actually, the data that we have evidence on it is asthmatic people who are gaining weight, their asthma went out of control with more weight.
Okay, any other questions here? So, Dr. Omar, Mike.
Assalamu alaikum, Dr. Omar Shamma. Thank you all for the very nice presentations. Dr. Ahiba, Dr. Mariam, Dr. Ahmed, all very awesome presentations. I learned a lot. It was up to date and full of practical tips. So thank you very much. Dr. Hiba, you touched on a point that I thought it's very important if you could elaborate more on that, which is building partnership with the patient. So any practical tip on doing that, any practical tips on making sure the patients have realistic expectations on the treatment plan or the prognosis? I think some patients come to the clinic expecting a magic cure, expecting that you will give them medications, not understanding that it's a chronic disease, needs a lot of follow-up, and sticking to the detailed treatment plan as you all mentioned. So any practical tips on building that?
So yes, we're in family medicine. We usually have this partnership with the patient in all diseases we tackle. And in asthma, it's very important to tell them that the level of control is really, it's not day by day symptoms. It's not if they wake up only at night. So they have to commit to their medication, whether they have symptoms or not in case of acute exacerbation, to take their control of treatment as instructed, to watch out for their any red flags for acute exacerbation, to avoid any allergens, exposures, it all should be written in the asthma action plan, when to step up treatment if they are having an upper respiratory, things like this.
Thank you.
And actually, yes, I want to add one thing, one more point to what Dr. Omar said. I think the shocking news that every patient receives in the clinic is, I want a cure for my asthma. Sorry, there is no cure for, sometimes there is no cure for asthma. It's like diabetes, it's like hypertension, it's like heart disease. And sometimes we need to take our medication on a daily basis. Then like, no way, there was people who was having asthma during childhood and then it disappeared. Yes, it exists, but it's the minimal percentage of asthmatic people. So we have to tell our patient the reality and the truth from the day one of clinical visit.
Okay. So, Dr. Mariam, from the practical point of view, once we start initiating the ICS, this will be opposed totally with a full resistance from the patient himself or herself, stating that this is a steroids and cortisone.
Yes.
So they are afraid of being addictive to it or getting diabetes or having some kind of osteoporosis and so forth. So how just to practically change the mindset of those patients?
Yeah, these are the the frequently asked question by the patient. So actually no one get addicted to inhaler. And the example that I always give in a clinic, other than a strong evidence that we said, like, this is the real practice. For example, I always ask them, if you have any other disease, diabetes, yes, you are taking your medication on a daily basis. Yes, did you get addicted to this medication? No. Can you stop this medication? No, you have to continue this medication. Yes, this is the same for asthma. You have to know that. So no one got addicted to inhaler. The patient who think that they got addicted to inhaler are the one who's having chronic persistent asthma. On the other hand, there is a minority of people, or not minority, kind of like good percentage of people who's having seasonal allergic post triggers, etc. So they can stop their inhaler every now and then. And they can be on just as needed inhaler, but there is different type of asthma. They should know that from the beginning. Number two, concerning ICS and steroid effect, there is no, this is just a local effect. There is no systemic effect of inhaler containing corticosteroids. We can give it to pregnant women, 9-month pregnancy. There is no side effect. أنا بقول لهم على مسؤوليتي, if you gain weight, come back to me. If you will develop osteoporosis on inhaled corticosteroids, come back to me. And most of them got convinced.
Okay, very good. There is a question, but for any one of you, when immunotherapy is indicated in the treatment of asthma, and what is the role of family physician in this?
Immunotherapy, meaning biologic treatment,
Yeah,
or
biologic.
meaning the biologic treatment?
Yes.
So yes, for mostly talking about severe asthma, in all guidelines, step 4 and above, people who are having recurrent asthma exacerbation, recurrent corticosteroids intake, non-improvement on high dose of inhaler, and hospital admission at least once per year. And then here we stratify them based on their phenotyping, IgE level, absolute eosinophil count, etc. There is also other criteria like severe nasal polyposis, recurrence, atopic dermatitis association, or other allergic pattern. So these are the patient candidate for biologic treatment.
Okay. Dr. Ahmed, the hyperactive airway disease following viral infections, can it be considered as a bronchial asthma that could be treated by the same way?
Actually, that's a very good question. I don't think it could be considered as asthma, but it could be maybe treated by the same tools, but it's not diagnosed as asthma. This from my perspective.
Not asthma unless it's recurrent.
Yeah.
Every viral illness, they develop asthma symptoms. So yes, this is asthma triggered by viral infection.
Okay.
But it's a solo symptoms or solo episodes, so this is not asthma.
And reflex esophagitis with bronchial asthma, what is the associations?
So reflux esophagitis exacerbate pre-existing asthma, but it does not cause asthma by itself.
Yeah. Dr. Hiba, there is a question for you. How to step down control to help confirm the diagnosis of asthma? Just in brief.
So I mentioned in the first slide about how to step down. First, you have to make sure that the patient is controlled with good lung function. They're not having any viral infection or any like travel or exposure to any allergens, or they're not pregnant. And then you start decreasing the controller treatment in partnership with the patient, 25 to 50%, and you reassess every 2 to 4 weeks with repeated lung function and asthma questionnaire to check if there is developing of symptoms or not. I hope I answered.
Yeah. Thank you so much. What is a disease that mimic or mask asthma? From the common...
So they are very numerous. The most commonly seen one, I would say, congestive heart failure, common presenting with wheezing. ABPA, one of the also not so uncommon, but not so common also at the same time. COPD, obstructive lung disease. And non-smoker, we always consider them as asthma, and then digging into history, we found them highly exposed to biomass, wood fire or bukhur or something like that. There is a lot, actually. I've mentioned all of them. Let's say Shark-Strauss disease, as we said, bronchiectasis, and then the vocal cord dysfunction, or what we call exercise-induced laryngeal spasm or upper airway spasm. Actually, I think every adult asthma patient should have one visit to ENT for evaluation of the upper airways. What else? Also, there is a lot. Actually, I think we've seen a lot of, endobronchial lesion. Okay. One of the most challenging cases also, any endobronchial lesion might present as wheezing. That's it so far. So, there's a lot.
So what is the role of short courses of prednisolone in the management of acute attack of bronchial asthma?
Anti-inflammatory.
Anti-inflammatory.
Yes, definitely. A strong anti-inflammatory to fasten the recovery of the patient.
Okay. So which guideline we should use, Cena or Gina?
I think practice-wise, they're almost the same.
Yeah, but there is some
There's some a tricky name, if I want to mention that. I would go according to patient by patient, what kind of inhaler they use, what kind of inhaler available at their wherever they're living or something like that. What kind of type of devices they can use also. I would go for the Cena Guidelines.
Okay, right.
Yeah.
So what will be your criteria to select the device or even the medications that have LABA, LAMA, ICS? On what basis your choice will be customized based on the patient?
Yes, of course. So first of all, according to the severity of the disease, step 1 and 2 only ICS. Step 3, combined ICS LABA. Step 4, we can add LAMA to triple therapy instead of just dual therapy, and etc. And you mean the type of the device?
Yeah.
It depends. So I always ask the patient what kind of device they use. If they use an MDI with a very good technique, I keep it the same. If they use it with a very bad technique and they don't use a spacer, I move to another one, turbohaler or discus or something like that. And we have to check their technique in the clinic. And I think maybe with the young adults also, I would go for the MDI. Sorry, for the turbohaler and discus, or even MDI. And more elderly, I would go for MDI with a spacer, more convenient with them. Almost that's it.
Okay. Any questions from the audience? We have 1, 2, Dr. Abdulaziz. Mike, please.
Well, thank you. Just a comment, I'm a pediatric endocrinologist, and I just want to mention one thing about the use of short course prednisone. The problem, sometimes those children go from one doctor to another with acute exacerbation, and they keep prescribing for them oral prednisone or prednisolone for relief of the symptoms. My advice is that this should not be more than 4 or 5, maximum 5 times a year. If it's more than that, you might induce cushingoid, and you might put also the adrenals to sleep, and it will be a problem. So if it's not improving, please ask and make sure that he's not taking too much. If it is, then you go to the guidelines, which is not to use too much oral steroid. Thank you.
Okay, thank you. We have here Dr. Munira. تفضلي.
First, I would like to thank you all for all these good informations and important informations. I just want to emphasize one thing, which is the health education about the use of all these medicines you have mentioned, the correct use of them. And you said, Dr. Hiba, that you saw, and also you, doctor, many cases that very bad methods of using these inhalers. So we need to emphasize and train the mother or the healthcare taker of that patient of how the correct use of the inhaler. Okay, thank you very much. That's all.
Okay, thank you so much, Dr. Munira. Because of the short of time and we have to close, I will just drop the bomb by asking the $1 million question to Dr. Mariam, as usual. How do you look into the practice and the quality of care of primary care physicians who are family physicians, both of us, myself and Dr. Hiba, sitting on the other side of our healthcare system in the hospital, looking into how we perform, how we diagnose, and how we treat and how we follow? Any hints, any comments, any things that we can improve our quality of care to our patients?
I think that the worldwide healthcare system is moving toward a primary care healthcare system instead of subspecialty.
Yes.
I don't know if this is going to be the history here also someday. So you're going to be the main fighter and the
Gatekeeper.
Exactly.
Yeah.
For every single disease, including asthma. From my practice over the past 5 years, I don't want to say it in your face.
Are we doing good?
You're doing great.
Okay, that's good. Thank you so
Yes.
much. Any last comment to improve our quality of care from your own perspective towards our patient with bronchial asthma and
I
primary
think we're
care?
just all hesitant, including myself, and tapering down actually the treatment, because a lot of our patients are maintained on a high dose inhaled corticosteroid, regardless of the side effect. I know that the side effect window is very small, but a lot of our patients are maintained by default on a high dose inhaled corticosteroids, and we don't do a lot of taper down, unfortunately.
Okay. But I think with this, we will come to the end of this scientific event, and I would like on your behalf, all of you, to thank our guest speaker, Dr. Hiba Bzia, Dr. Mariam Sheikh, Dr. Ahmed Juma, for the wonderful contributions for the success of this event. And I would like to extend our thanks to GSK for giving us this wonderful opportunity, and for all of you to attend physical, and even for those who are attending with us virtually, more than 1,700 attendees. And thank you for the quality of questions that we have received. I'm just reminding you that this was one session of the IMC Family Medicine Club, and stay tuned for another session, inshallah, will be coming immediately after our Eid. With this, I would like to thank you all for being with us here, and I wish you a wonderful night. So we will have the dinner together. Thank you so much for all of you.
you.